In this episode of our myth-busting series, we'll unravel the myth that atopic dermatitis is just a Th2 disease and explore how this idea oversimplifies the heterogeneous nature of AD. There are a few reasons why this myth came about. Let's take a closer look. Around the 1970s, AD was predominantly viewed as an IgE-mediated disease. About 80% of patients with AD have high IgE. Over the next couple of decades, accumulating research pointed towards Th2 cells as key players in the pathophysiology of AD, acting through IL-4, IL-13, and IL-31 to drive inflammation, itch, and skin barrier dysfunction. This led to the investigation of therapies targeting molecules in the Th2 pathway. The first approved biologic for AD, targeting IL-4 receptor alpha, transformed the therapeutic landscape in AD and paved the way for more Th2-targeted therapies. Additional support for the role of the Th2 axis in AD stems from observations that patients with AD often have other atopic diseases, classically considered as Th2-mediated, such as asthma in 25% of patients, food allergy in 11%, and allergic rhinitis in 29% of patients. It's critical that we dispel this myth to ensure patients receive a treatment that addresses the full spectrum of disease phenotypes when appropriate, not just a single pathway. So let me show you why AD is not just a Th2 disease. As well as the Th2 immune axis discussed, the Th1, Th17, and Th22 pathways are also activated in AD and sustain the skin inflammation, itch, and skin barrier disruption. The extent of involvement from each of these pathways depends on the stage and severity of AD. Th22-mediated responses are activated in acute lesional skin and intensify as disease severity increases, while Th1 and Th17-mediated responses are activated in more chronic skin lesions. The cytokines released by Th22, Th17, and Th1 cells mediate different responses in the skin of AD patients. IL-22, produced by Th22 cells, induces responses such as suppression of keratinocyte differentiation and epidermal hyperplasia. IL-17, produced by Th17 cells, induces and augments skin inflammation and works with IL-22, causing barrier defects in human keratinocytes. Interferon gamma, produced by Th1 cells, downregulates tight junctions and increases keratinocyte apoptosis. AD is often defined as a complex and heterogeneous immunoinflammatory disease. One reason for this classification is the different clinical manifestations, or phenotypes, of the disease, which are characterized by a diverse range of underlying molecular mechanisms known as endotypes. We've already spoken about how several immune axes play a role in AD pathogenesis. However, different groups of patients with AD have different combinations of Th1, Th17, and Th22 immune activation, alongside dominant Th2 activation. These groups of patients can be categorized according to age, ethnicity, and severity of the disease. Let's look into this further by explaining the endotype profile for a few patient groups. Pediatric AD shows elevated Th17-related cytokines, which are most exaggerated in infants less than 5 years of age, and Th9-related cytokines with lower Th1 activation. On the other hand, adult AD is characterized by Th22, Th17, and Th1 activation. Asian patients with AD, including Japanese, Korean, and Chinese patients, have accentuated polarity of the Th22 and Th17 axes compared with European American patients, together with lower Th1 marker expression. African American patients instead exhibit Th1 and Th17 attenuation with Th2 and Th22 immune skewing. Patients with more severe AD appear to have an elevated inflammatory biomarker profile with a marked increase in circulating Th2 and Th22 cytokines. There is no doubt that underlying immunoinflammation in AD is predominantly driven by the Th2 immune response, as evidenced by several approved and investigational therapies, such as those targeting IL-4 receptor alpha, IL-13 receptor, IL-31 receptor, and CCR4. To address the complexity of AD, new therapies are being developed that target molecules beyond the Th2 axis, such as IL-22, which we discussed earlier, and the OX40-OX40 ligand pathway, which is involved in antigen presentation and co-stimulation. Small molecule inhibitors include oral and topical JAK and PDE4 inhibitors. JAK inhibitors differentially target JAKs, involved in the signal transduction of multiple cytokine receptors, including Th2 and non-Th2 cytokines such as IL-4, 5, 13, 31, 22, and interferon gamma. Similarly, PDE4 inhibition results in inflammatory cytokine suppression of Th2, but also other pathways such as IL-4, 5, 13, 22, and interferon gamma, and GM-CSF. It is important for us as dermatologists to appreciate the full spectrum of disease pathophysiology in AD. By dispelling the myth that AD is just a Th2 disease, we can better understand this disease to ultimately ensure that our patients with more severe disease receive the proper treatment and care.